Hello, everyone, and welcome to today's program, Implementing Centralized Electronic Prior Authorization, presented by Surescripts and Aurora Health Care and hosted by Health Leaders Media. My name is Erica Randall. I'm the Senior Managing Editor for Health Leaders Media, and I'll be your host for today's webinar. Our program will be 60 minutes in length, and the first portion of the program is a presentation followed by a question and answer session by our audience. Today's program is being recorded. Before we get started, I'd like to just take a moment to review our web conference platform. First, to ensure that you can see all of the content for the event, please maximize your event window. Second, be sure to adjust your computer volume settings or your PC speakers for optimal sound quality. Third, you'll see at the bottom of your console that there are multiple widgets that you can use. For example, to submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. That widget is for if you want to submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. We're very pleased to offer you this free educational opportunity by Surescripts and Aurora Health Care. Now I'd like to introduce today's speakers. First, we have Philip Kissick, MHA MSRD, Senior Project Manager for Advocate Aurora Health. Welcome, Philip. Next, we have Dahlia Saleh, and she is the Manager of Pharmacy Operations for Advocate Aurora Health. And finally, we do have Luke Forster Broughton, who's the Manager of Product Innovation for Surescripts. And lastly, before we get started, note that an on-demand version of this program will be available approximately 1 day after the completion of the event and can be accessed using the same login link that you used for the live program. Also, a copy of today's presentation is available in the Resource List widget, which is located in the lower left area of your screen. And with that, I would just like to welcome our speakers again and pass the program over to them.
Thank you, and I appreciate the opportunity to be here today, and thanks for the introduction, Erica. My name is Phil Kissick, and what I'm going to do is start with a review of the traditional prior authorization model. And not unfamiliar to most of you, whether you've worked in the clinic space or been subject to this process as a patient. And this shows the traditional prescription prior authorization process. And what you'll see here is we're going to move from left to right and flow through here. But what you'll see is 4 lanes or rows. One starts with the prescriber. The next is the PBM, which is short for Pharmacy Benefit Plan. Essentially, that's the patient's pharmacy part of their insurance. Then we have the pharmacy itself, and at the bottom we have the sickly patient here in this case who is subject to this process. So you'll also notice as we go there is some color coding. Some of that's going to be self-explanatory, but you'll see how we work with that as we go. So just starting a brief review of this, we go from the prescriber's office or the clinic where your physician or advanced practice clinician will order the prescription. Okay, that method gets translated down to the pharmacy, and in many cases it's an electronic process. Sometimes it's a paper script that the patient brings into the pharmacy. In general, we have these colored green because they tend to be fairly efficient processes. The next, though, and this is where the trouble begins, we start with the arrow that moves back up into the PBM space or the pharmacy benefit plan. This is where the pharmacy has attempted to bill the insurance but has received a rejection. Okay, I have this in yellow because certainly from most people's perspective it's not ideal, but it's one of the necessary evils of the world we live in, and so you're going to get rejection. So why I have that yellow and not red. So when the rejection occurs, what's going to happen is the pharmacy is going to let the patient know we need a prior auth completed on this, and then they're going to fax the clinic. Now, again, going back to that poor patient here, you'll see a long red bar that will continue throughout this process, and essentially that's to note this is a pain point and they're stuck waiting through the process. That is not necessarily anyone's fault, but it's the reality of what we've seen current state at Aurora, what I've seen other places I've been in, which you're probably familiar to. I would say this is more of the rule than the exception, without a doubt. So then moving back up to that first row, we've gone from the attempt to bill rejects due to the PA requirement, and the pharmacy has faxed the clinic or the prescriber's office to complete the prior authorization. See the big Kapowie lean symbol in there representing this is a mess. It's no fault of anybody's other than how things have traditionally been set up. You have competing interests here, competing priorities. In many cases, this prior authorization work is done by nurses who are being called away to triage patient care. They're helping physicians with in-office procedures, a lot of different competing interests. And so it's not uncommon that this paperwork they're going to start gets pushed aside. And so that paperwork in itself can be a little bit of a guessing game. Which form do I want to fill out? What particular pieces of the form need the most detail, or does the entire form need to be filled out, which can be quite a lengthy form. So in some cases, then there's a phone call to the pharmacy benefit manager, pharmacy benefit plan, and we know how phone calls can go. You can be on hold, you get into decision trees, which department you want, or you may be on hold and then have to drop off because you have patient situation in the clinic that needs to be addressed more critically. And so it gets into lots of, probably do 3 or 4 slides just on this, but for the sake of time, I'm going to move into the next slide, and we're going to assume that the request for prior authorization or the request for approval does occur. The pharmacy benefit plan or the insurance company approves the request, and the process then flows reasonably smoothly from there, with the pharmacy filling the prescription and notifying the patient, who then receives their prescription. One of the pieces that's in here is just being facetious, but a small little piece of information is to know that there's also data out there that says, so not only has this patient been waiting, not feeling well for their medication, but also that they're less likely to ever get the medication filled the longer they have to wait. And so there we've got a double whammy there for problems from the patient's, from everyone's perspective who's trying to help provide good care. I'm going to move into the next slide, which is the post-implementation prior authorization. And I'm not going to spend a lot of time on this one here, except to say this is where we started from our project plan. Originally, this is what we were going to do, and as you'll see on this, again, the 4 lanes there, prescriber, PBM, pharmacy, and patient, that a lot of the yellow and a lot of the red have turned to green. So we've made these efficient processes. And so that's a real positive. I'll move into the next slide in a couple minutes and talk about the yellow piece here on this slide. But so in general, what happens without a lot of the nuts and bolts behind the scenes computer pieces is that the prescription is ordered, and there's a little flag that comes up in the system that says, we think this requires a prior authorization. And in a lot of cases, that's not necessarily true, but it's partly how your health system or clinic would load formulary information and patient insurance information. Again, I don't want to go into too much detail there, but just know there's a flag that says this might require a prior authorization. and in which case it goes to the pharmacy benefit plan, who then will make that determination if it doesn't require a prior authorization. So the pharmacy will go ahead and fill this prescription and the patient receives their medication. If it does require a prior authorization, then we're going to flow back up from here. The green diamond is a PA truly required, and we're going to flow into the yellow box where we have the clinic answering the questions to a specific question set that is generated from the pharmacy benefit plan electronically. So instead of that paper form that's being filled out, now you have a set of these are the questions we really need answered. So you've taken guesswork out of that. There are still some challenges, of course, with this. Competing priorities. You're getting the nurses who are generally working these prior auths are getting called away from other things. They're triaging incoming patient phone calls, sick patients calling, needing to know whether they should come in or not to the clinic. And so, but nonetheless, it does flow, and we do have an improvement here. I'm going to switch to the next slide for continuation here. And I'm going to reference now, we've actually moved that yellow box up and added another lane. And this lane is the central prior authorization team. Here we've turned that yellow box by moving it from the clinic up to the central PA team to answer the dedicated specific questions. The reason we felt doing this was important was because it allows for a dedicated team who gets to specialize, and I think Dahlia is going to talk a little bit more about that, but who specializes, and this is their full-time job, is to work prior authorizations. And so you've bypassed the clinic there, freed the nursing staff up, and those questions are answered by the central PA team, who then will electronically send their responses to the pharmacy benefit manager, who will then either approve the prior authorization, flowing down to the pharmacy, filling the medication and notifying the patient, and the patient receiving the prescription. All of this, again, has condensed the process much quicker, much more real time. Or the pharmacy benefit plan, moving up the lanes, has denied the prior authorization and notifies the central, a message comes to the central prior authorization team, who can either problem solve, and some of the stories behind things these folks who have this as a full-time job can do to problem solve and resubmit, get things approved, is probably more time than we have today, but it's neat to say the least. Or they'll notify the clinic, and the clinic will determine, do they want to appeal the denial, or do they want to have the physician order a different medication. Now I'm just going to talk about the rollout strategy that we utilized, and mention just briefly that the plan was not originally to centralize our process, and EPA lives on its own, as you saw in that second diagram, without prior authorization. And I just want to stop and say we took about a year to make the determination on a vendor, go through the contracting process, and Surescripts was brilliant working with us throughout this. Completely helpful. I'm not being paid by Surescripts, by the way, but I wanted to make sure that was very clear how impressed I have been as the project manager with Surescripts throughout this. So once the decision was made to centrally to move this process to a central prior authorization group, then we moved forward with a go live starting in September of 2017. One of the things we wanted to do is make sure we were setting ourselves up for success, and this is brilliance on the part of Dahlia and the pharmacy team involved here. They freed up 1 to 2, I think there were 2 pharmacy technicians to help us start the process and to learn as we go. And the sites we chose different regions so we could get a little bit of experience with different insurance plans that exist within our geography. But then we also wanted to focus on primary care with the exception, though, of oncology. And the reason we selected oncology was because there were some strong relationships that existed already within oncology. And Maggie Rasick, for example, one of our folks, used to work in the oncology suites and had developed terrific relationships. And so setting ourselves up for success was huge, because not only were we going to need their support in making it a great process, but we were going to need their support in collecting data and also spreading the word, particularly if they were happy, and spreading this to the system that this is something you want, which was so important as we look to get more FTEs to roll this out to the rest of the system. So with that, I'm going to pass the baton over to Dahlia to talk about the post-implementation benefits.
Thank you, Bill. So we knew that early on with our initial sites, we were going to want to collect some data, because ultimately we knew we would likely have to ask for some approval for staff members for the central team, FTE approvals. And we also knew that at some point we would need to get some strong support from clinic leadership and frontline staff to move on to this process. So being able to let them know what to expect and what the benefits were very important early on. So here's some of the information that we gathered, and what we saw in our time studies for pre-go live at our pilot sites is that it took on average 3.8 days for clinic nurses and MAs to start working on prior authorizations. So that's 3.8 days after the script was written for them to start working on it. That's the first really big piece of learning that we saw. This is not because of negligence by the clinic, but you'll find that across the country this is essentially due to the inherently retrospective nature of prior auth, as Phil described earlier, and the fact that this also is a task that's handled by staff who have a multitude of other responsibilities. And beyond that, they're also dealing with drug insurance, which is usually not something that they necessarily were trained for or went to school for. So, even those in pharmacy can have a fun time jumping through the hoops that related to drug insurance approvals. And so we were actually able to bring that down significantly when we went live, and we saw that 75% of prior auths were actually completed the day after the order was written. So that was already a huge piece that we saw right away that was very exciting to share with clinics and the organization. We also saw that we were able to reduce the amount of active time that was involved in taking care of the prior auths. Part of that is related to, as I said, having pharmacy techs who understand insurance working on this, but it also was related to the efficiencies gained by the technology that we turned on in Epic through Surescripts. So those were some very exciting pieces of information we saw early on. We also gathered some great feedback from the sites as well, and you'll see here some physician quotes. We knew that there was a lot of benefit being felt by the nurses and MAs who traditionally work on prior auth at the clinics, but we were pretty surprised to actually also see how much the physicians and prescribers were feeling the impact of turning this on and centralizing the work and removing it largely from their sites. So here you can see that a recurring theme is less paperwork for the physicians, and they also felt like the delay in patients getting their medications was less. We also, along with that, saw that with less work being done by the frontline staff, some other tasks were getting addressed more quickly. The in-basket was cleaner, and they also repeatedly, we heard that patient messages and calls to the clinics were getting dealt with much more quickly because they didn't have to be stuck on the phone with insurance companies dealing with prior auths as much. So very great news. The other thing that we saw was that, or that we heard initially, was that staff were leaving on time. And this was specifically nursing and MA staff, because they didn't have to deal with the prior auth anymore. So that was something we kept in mind. So we started putting together a business case in order to get that central team approved and support the further rollout of our project beyond the initial pilot sites. So there were some initial pieces of information we had. We were able to initially look at some figures across our system. We pulled Epic data to see how many prescriptions were written across our roughly 150 Aurora clinics, and that's just clinic locations. Within each clinic, we have multiple departments. And then from that, we also saw that about 2% of all the prescriptions were in need of prior authorization. That was something we had received initially from Surescripts as an estimate that we would get between 1 to 3% of all scripts resulting in a prior auth to our central team. But that was something we were able to validate as a rough estimate in our initial sites, which was very important for us to be able to determine how much work we were going to be doing to support this across the system. We took into account central prior auth team time study. So with those pilot sites, how long was it taking us at the central team to get through the prior authorizations? And so through all of these different elements, we brought that together and did some math and estimated that it would take about 18 FTEs plus a supervisor to staff that central team. So now came the question, since we didn't want to take the approach of suggesting that we're going to be cutting clinic staff in order to justify or get approval for the central team, how do we help demonstrate some value to offset the costs associated with this request when we took this to organizational leadership for approval? So based on, like I said earlier, based on some feedback from clinics, there were a few things we decided to look into, and one of those was reduction in overtime. We were actually able to demonstrate a 51% reduction in overtime, as you can see here. And the only thing that changed, so that happened here in the middle month, you can see a drastic decrease. And the only thing that happened that changed in that month was that we turned on EPA. So we had heard anecdotal data that people were getting out on time, and here we were also able to demonstrate that with actual numbers, which was very exciting. That obviously has financial implications. The next thing that we looked into was related to prescription pickup rates. So at Advocate Aurora and at Aurora Health Care specifically, we have integrated pharmacies that are also on Epic, retail pharmacies that are also on Epic. And so we were able to actually look at how frequently our patients were picking up prescriptions from the clinics that went live. We did pre and post data to see how frequently prescriptions were going into that dispense status. We pulled that data out of Epic, and we had estimated that, or we had hypothesized essentially that since these patients were getting a phone call after their appointment by that central team, we know that there's data out there that talks about how follow-up phone calls increase medication adherence. We hypothesized that they may be picking up their medications more frequently. And when we looked at our data between our clinics and retail pharmacies, we did see that there was an increase in the rate of actually selling the prescriptions to patients. So really awesome implications there related to medication adherence, but also some implications there for prescription revenue. So we had some of that hard data to speak to, but we also wanted to bring some really great patient stories to the approval board. We knew that these were some things that were getting strong physician and clinic frontline staff support, and we knew that would also speak volumes in terms of actually getting financial support to continue this project. Because at the end of the day, healthcare organizations, our primary goal is to take care of patients as best as we can. So a couple of the really powerful stories we brought are included here. And the first one is just related to the endless back and forth cycle that happens today dealing with prior auths between clinics and pharmacies and insurance companies. We uncovered multiple stories where we actually saw that the central team figured out that some of the back and forth that was happening and phone calls the clinics were doing, they weren't actually prior authorizations that were needed. It was actually a lot of miscommunication between those external pharmacies and the clinics, where they were getting faxes from the pharmacies that made it look like a prior auth was needed when in fact it was something simple like a refill too soon. And at the central team, we were able to intercept that. Our pharmacy techs who were staffing that knew what that was. They understood the retail world. They knew this is not a prior auth that I need to work on. I just need to follow up appropriately with the patient and the clinic to let them know this is just a refill too soon that the patient is attempting. So the lesson learned there is having the right people see the messages and intercept this process and disrupt it can really help to get rid of some of the noise and huge time wasting that's happening at our clinics that impacts patients. The second, it relates to some great examples where we saved patients money. So this is an example where we actually had a prescription. It was a metformin, very costly version of it that was prescribed. The central team actually did the prior auth for it. However, that external pharmacy was still quoting a price of $3,000 to the patient for a 3-month supply. Patient reached out to the central team and said, I really can't afford this. Understandably, they were not going to take that medication at that price. The central team actually ended up helping identify a discount program that the patient could utilize. They switched to an equivalent medication with the help of the on-call pharmacist and clinic. And they actually got that essentially clinically equivalent medication for the patient for $17. So it's just that layer of problem solving, again, that is so valuable in having a central team working on drug cost issues for patients. The last example is related to incorrect prescription billing. So this is an example of where the central team identified something at an external pharmacy that was just being billed incorrectly. It was test strips. It was being sent to one part of Medicare where it's supposed to be getting billed through a different part of Medicare. And that central team troubleshooted that, fixed it, got it to go through for $0 instead of a really high copay. So again, extra layer of problem solving related to drug costs for your patients can make a huge impact, might be cleaning up issues that we don't even know our patients are facing out there when they leave their clinic appointment. So we pulled all of this financial information together and padded it also with the great patient stories that we just shared. Pulled that together and basically we're able to estimate the central team costs overall. We offset that with a 20% clinic overtime reduction savings and the 1% and a 1% prescription dispense rate increase in gross profit. And as a reminder, in our actual pilots and early sites, we saw 50% or 51% overtime reduction and up to 6% increase of prescription dispense rates. We didn't want to overestimate anything. We wanted to be conservative with the math we were doing, so we reduced that to 20% and 1%. But essentially, that's what we were able to use to demonstrate that the central team could basically pay for itself with this project. Along with this, and just to back up, we set those goals at 20% and 1% and had the conversations with the approval board, feeling that in our conversations with the initial clinic's leadership, this was an attainable goal. So we wanted to make sure that what we were suggesting as far as this project paying for itself was realistic as well. So that's kind of how we landed on those numbers. So then, along with that conversation, a couple other strategies that we used just to add these bullet points. We knew that RNs and MAs were primarily the type of staff working on prior auth at the clinics prior to the pilot, and so we also knew that there was a huge shortage in especially MAs at clinics, and this may or may not be true at your locations across the country, but basically what we're seeing in talking to our recruiters and clinic leaders is that they may have multiple MA positions posted and desperately needing to fill them, but they would basically not have anybody hired in for months because of how bad the shortage was. So what our suggestion there was to even further help offset the cost of the central team and the project. We suggested evaluating some of those locations that maybe had multiple MA postings out there and seeing if they would be able to potentially eliminate one of those postings and be an earlier adopter for the EPA rollout. So that was one of the things that kind of helped, it was part of our strategy. Another part was having some of the market leaders who are very excited to get this to be live at their market within Aurora, to see within themselves where they might be able to donate some FTEs here and there to the cause, essentially. One of the nice things we were able to do was to actually let each market leader know, based on the prescription volume coming out of their clinics in their particular market, what that translates into in terms of FTE needs and essentially workload. So once you put it into numbers that way and say, hey, you know, for your market of clinics, that is actually taking up about 2 FTEs of our team, that actually, you know, was a really nice conversation starter and got people to look at things a little differently in terms of what they would be willing to help donate as far as FTEs to the central team out of their market. Those are just a couple things we wanted to share as strategies that we used. So moving on to the next slide here, just some overall lessons learned. Truly, centralization provides the optimal efficiency and benefit out of this software based on our experience. We had the option, as Phil mentioned, to turn this on and essentially let the clinics try to use the software as much as possible to get the benefit and reduce prior auth work individually. But one of the biggest things we saw as an advantage in terms of training and rollout was we didn't have to train all the clinics and all the nurses and physicians and MAs really how to deal with prior auth and all the work on the back end using the software. We just had to give them a very easy one-button step essentially that they did, and we centralized all the work to pharmacy techs who really know their stuff when it comes to medication prior auth. That really brings me to the second point, that we did see a very big difference in just how easily the pharmacy techs were able to maneuver through some of the insurance issues and formulary issues. So at least early on in your team, I think it's important to have a solid pharmacy tech background as part of your staff. Lastly, one of the wonderful things about this project and the software and everything we were doing here overall is it's one of the few things you take to your clinic as a pilot or an upgrade that truly reduces the work that they are doing day to day. We've literally had, you know, after our initial rollouts, we've literally had clinics coming to us asking to be next for the go live and really excited about it, wanting to know when it's going to come to their location, which isn't always the attitude and perception that you have on things you're rolling out. So using that frontline caregiver, provider, and also leader support in making our business case was very important, and I feel that it was a big factor in us getting approval, that it wasn't just us as this small team coming to ask for approval, but that board had already heard about how popular this was and how much people wanted it from many other voices as well. So that is overall a summary of how we got approval for a rather large team of staff members to help do this across our large organization of ambulatory clinics. And I'll pass this over to Luke to talk a little bit more about the technology behind the magic.
Thank you, Dahlia. This is Luke Forster-Broughton. I'm a manager of product innovation here at Surescripts, and I oversee our electronic prior authorization product. So I wanted to get into a few of the statistics and talk about some of the technology that makes possible all of the statistics that Phil and Dahlia just shared around their use of the Surescripts electronic prior authorization product. So one of the main reasons that we're able to return those real-time prior authorization approvals is because we are electronically connected to a large number of pharmacy benefit managers and health plans all across the country. So what we see is that because we have that full electronic connectivity, the pharmacy benefit managers are able to structure their questions in such a way that providers and their staff members no longer need to answer all of the questions they see in a prior authorization form. So based on the way that a user is answering these questions, she gets to skip to the next relevant question. She doesn't have to answer all of the questions, some of which might be relevant. So all of that time savings, it really makes it much easier to do prior authorizations, but also makes it a lot easier to get those responses back from the PBM. So what we've seen in the few years that we've been live with the product is that about 65% of the time, when the prior authorization doesn't have to have a human being look at it at the PBM, that's going to come back in less than a minute. So we work really closely and monitor our transactions to see how quickly our PBM and health plan partners are turning around these approvals. And the fact that they're able to intake that fully electronic question set, read it, and have their system go through it and either approve it or deny it, when it gets approved, a lot of times it doesn't have to have somebody look at it. So they're able to return those very quickly. And that helps achieve some of those metrics that Dahlia shared earlier around the time that it takes, where it used to take a long time to even start the prior authorization. Now they're starting and completing the prior authorization electronically much more quickly. So it's a lot shorter turnaround time in general. And so if we look at some of the key features of that prospective electronic prior authorization workflow, prospectively just means that rather than having it be a fully retrospective process that only starts once the patient is already at the pharmacy, the provider is able to see that the need for prior authorization as she's writing that electronic prescription. So she can see that the drug needs prior authorization, and she can either choose a different drug that doesn't require prior authorization, or she can choose the drug that does require prior authorization, knowing that she's got a centralized team behind her that is going to handle that prior authorization electronically on her behalf and get that turned around oftentimes before the patient even leaves the office. So that PBM that gets that request from Aurora can return that dynamic logic that's specific to the patient, the plan, and the medication, and make sure that the Aurora staff doesn't have to go outside their workflow and go to a portal and try to find the right form and maybe talk to somebody about what is the right form in this scenario. They're getting that electronic question set for the patient plan and medication directly within that Epic system, and they're able to answer those questions very quickly as they look in the patient's chart and then answer those questions. And the other nice thing is that because all of this information is coming from data that exists within Aurora already, they're not going out to a different portal or a different system to do the prior authorization. All of that patient demographic information, the provider information, the medication information, all of that is being automatically delivered to the PBM so they can send back that question set. Whereas in the past, all of that information would have to be manually typed into a separate system to be able to find what the right form was and to be able to answer the questions that the PBM was asking. So all of that goes away, and that reduces a lot of that administrative overhead that exists with manual prior authorization. And then as I mentioned before, that real-time prior authorization means that patients are getting the prior authorization done before oftentimes they even leave to go to the pharmacy. And so as you see here, that prior authorization process is identified during the prescribing process. There's a new solution that is coming that would allow a real-time benefit check that would be patient-specific. So rather than looking at kind of group or health plan level formulary data, which providers traditionally have relied on to identify the need for PA. That real-time prescription benefit check would be able to be run with the PBM. They could respond back with patient information about whether it needs prior authorization, and if it does, what would the cost of the drug be for the patient when they got to the pharmacy, so that the provider can have all of that patient-specific information about that specific drug at that pharmacy. That'll start being available more and more. So as it relates to prior authorization, they'll be able to see that prior authorization is needed, the centralized staff will take care of it, that prior authorization will get approved, and then when the patient gets to the pharmacy, they're able to pick that medication up without any issues. And that adherence that Dahlia talked a lot about is a huge problem, because what we see is that oftentimes some studies have shown that 40% of patients that arrive at the pharmacy and then get turned away because of prior authorization, they never actually pick up their medication. So that has a lot of negative health outcomes down the road for that patient, not only from a medication standpoint, but just in helping to manage their overall indication. So being able to get to the pharmacy and pick that drug up quickly is very important. And then also, as Dahlia said, because that centralized team is doing all the prior authorizations, it lets nurses and providers and all the other medical staff members operate at the top of their licenses. They no longer have to worry about all of this manual insurance overhead processing. They can really focus on patient care, and that centralized team is doing all of the fun stuff on the back end to get those prior authorizations completed very efficiently. So that integrated workflow means that it's happening prospectively as part of the e-prescribing process, being able to communicate directly with those PBMs and health plans who've got electronic prior authorization completely integrated into their systems, allows for that real-time response back from that patient's insurance plan. Only having to answer those patient-specific questions, not having to answer or to enter a bunch of demographic information and medication information outside of the user workflow, and it really eliminates a lot of back and forth. So because things are fully electronic, providers aren't even allowed to send an incomplete question set, which in the past was very easy to do, right? You could forget to populate a field, you'd send it to the PBM, and they'd respond back and say, hey, we need more information on this. That fully electronic workflow means that the PBM is getting all of the information they need on the first time, so they don't need to reach back out to the provider for additional documentation. And then at the end of the day, and most importantly, that patient and staff satisfaction, it goes right through the roof. So you've got that increased medication adherence, being able to identify the need for prior authorization at the point of care, and then making sure that there aren't any surprises at the pharmacy so the patient can pick up that medication without any issues. And now we'll move to the question and answer portion.
Thank you so much, Luke. And thank you to all of our speakers today. Luke is correct. We're now at the Q&A portion of our program. So now we would like to invite you to ask live questions of our speakers. And just as a reminder, to submit a question, you can click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewable by other audience members. So as our audience types in their questions, I will go ahead and ask a few. All right, so I'm going to ask for Philip or Dahlia to answer this question. Did you notify pharmacies of the centralized team so they fax PA requests directly to the centralized team when they get claim rejections for PA?
Yeah, I think this is probably one that, Dahlia, you might want to take.
Yeah, could you repeat that question one more time?
Sure, of course. Did you notify pharmacies of the centralized team so they fax PA requests directly to the centralized team when they get claim rejections for PA?
That's a really good question. So we had our internal pharmacies do that. We let them know about the central team so they could work with them instead of having to contact the clinics. It was just a nice service to help further reduce some of the messages and calls that the clinics were getting. As far as external pharmacies, we didn't do any communication out to them, so they would still be faxing things to the clinics. But what happens is that because of the way that the prior auth is intercepted, often the prior auth is resolved before it even gets to the pharmacy. So the occurrence of faxes happening from those external pharmacies back to the clinic was very much reduced. One thing we did do was we would often update fax numbers for things that were sent to the insurance company so that when they sent things back to the clinic, it would come to the central team instead of to the clinic, since that central team was working, is operating on behalf of the clinic. Hopefully that answers the question.
Thank you so much. I have another one for either you, Dahlia, or Philip, and that would be, with the central model, how has your team overcome the challenges in ensuring the clinical information supports the test? Is this model just used for prescriptions or other services such as MRI, CT, injections?
At this point, it's not used. Well, the model is used for other services, but this specific piece is for the medications. I would say the big thing is it's been the partnership overall, the regular meetings with IT leadership and making sure the pieces are flowing correctly. Dahlia, do you have more that you'd add to that?
Yeah, I agree with what you said. And then I would just add that we have a central team that, has historically helped work on some non-medication prior auth things for patients. That team is unrelated to the team that's working here. But as far as I know, there was no electronic process that's kind of proactively helping to resolve some of the prior auth obstacles the way that this is. And if there is, it's not something I'm aware of.
Okay. Dahlia, I believe you mentioned this during the presentation, but there is a question about how many PAs per FTE per day can be completed.
Yeah, that's a really good question. I think, so it really depends on a couple different factors, and I hesitate to say any specific numbers for a few different reasons. I would hate to put a number out there and have anybody run with it and base all of their estimates off of it. The kind of variables at play are the types of payers in your market. So you may have more payers that are fully on the electronic system. Those prior auths will take a matter of seconds to do. In your area, in contrast, you may have some payers that are not fully on the electronic system, so there's still going to be some faxing and paperwork involved. Those will be on the higher end and will take several minutes, up to even over half an hour at times if it's a really complicated one. That's very rare, but we did an average of about 14 minutes per prior auth per person, and I'll put that out there as our rough estimate. I would very much welcome anyone, if they have questions, to reach out to me to talk through some of the other variables that I think are important to consider if you're trying to make an FTE estimate. Just because I think that there's several factors to consider, but I will say that we use an estimate of about 14 minutes per prior auth per caregiver initially, and that has held pretty consistent. It's just to take into account the very quick ones, but also the longer prior auth and the time that's needed in between.
Great, thank you for answering that. Luke, I have a few for you now. The first one is, how do you handle denials and notifications to prescribers?
Sure. So the denials that come back from the PBM includes a lot of the information that would be in your traditional denial letter, and oftentimes they attach a PDF of the actual denial letter. So in the denial notes, they'll indicate that the drug was denied. They might indicate why it was denied. They'll also offer the number to call if the provider would like to appeal that denial. And then what we've seen more and more is that a couple of the PBMs are starting to enable electronic appeals as well. So they'll also let the user know that if they'd like to appeal, that appeal is available electronically. And then that appeal process can follow the exact same process that the initial prior authorization did with that conditional logic and making sure that the PBM is getting all the information they need to adjudicate that appeal. But I think Dahlia would be able to speak to this a little better, but traditionally what we've seen is that those denials are appearing on the user's work list, and then they've got whatever their process is in place for either appealing or for helping the provider select a different drug is typically what we see with those denials.
Right, and then my second question, and let me know if you need me to repeat it, it's a little long. How accurate is the identification of prescriptions needing a PA? If PA is not identified and a prescription goes to pharmacy and you get a PA request from the retail pharmacy, how do you manage that workflow outside of the EPA process?
Yeah, I can answer that question. So there are definitely, I would say it's a small portion. I don't have an exact number of how many still get through to the pharmacy and are incorrectly unflagged by the system. When I say flagged, that is when the Surescripts software essentially gets a response from the PBM that lets it know there may be a prior auth needed, which then routes it to the central team before it gets to the pharmacy. So we don't see that happen very often. Maybe Luke has more actual concrete data on that, but what I will say is that when it does happen and something gets through to the pharmacy, that pharmacy, obviously, if it's an external pharmacy, they don't know about our central team, so they would still fax things back to the clinic. What our central team has done is we've really leveraged Epic in-basket messaging to allow the clinics to still route that information to us. So we set up a central fax number for our team, and we have an in-basket pool for the team. And basically, whenever we went live at a clinic, we told all the staff there, if you do still get anything regarding a PA for medication from a pharmacy, don't worry about dealing with it, just send it over to us. So they would then in-basket message us or fax things to us, or both.
Great, thank you. Luke, I have another one for you. Do you have contracts that you set up with payers?
We do. So we contract with as many PBMs and health plans that we can. So virtually all of the largest payers are currently contracted with the service. So CVS Health, Express Scripts, Optum, Humana, et cetera. So we are working very hard to continue to expand to all of the providers, all of the payers in the country. But we do, there are just going to be some cases where payers might be a little slower to adopt. Some of the Medicaid plans are a little slower to adopt, and so we do have a backup solution in place where if electronic connectivity is not available, we have a service where we can provide a fillable PDF of the form. Again, this is right within the Epic workflow, so instead of getting an electronic question set back, the user gets a link that they can click that's a fillable PDF of that prior authorization form that can get faxed to that health plan that's not electronically connected yet. So it's a good safety net and a way to make sure that we can process as many prior authorizations in the Epic workflow as possible while we continue to build out and strive for that fully electronic connectivity that I was discussing earlier.
Okay, great. And Luke, also, does Surescripts have a program to help hospitals with the prior authorization for outside hospital drug administration? The hospital is providing the drug.
So if I'm understanding the question correctly, this would be for like specialty drugs where the provider or the hospital system has them on site and is administering them as part of, it typically as part of the patient's medical benefit. That is currently not covered under the electronic prior authorization solution. So right now we utilize the NCPDP script standard for EPA, which is for the medication side of things. So if the drug is covered under the patient's pharmacy benefit, then that would be available for electronic prior authorization. If it's covered under the medical benefit, then that's not part of the solution today. And I think the industry in general is still trying to figure out how to make electronic prior authorization for the medical benefit more of a reality. And we've been involved at Surescripts in a lot of work groups across the industry to talk about the successes that we've been able to see with the NCPDP standard for the pharmacy benefit to see if that would also work for the medical benefit. So there's still a lot of work to be done there, but so right now it is focused on the pharmacy side, but we're looking to see how we can leverage that for the medical side as well.
Okay, and Philip, I have one for you. Understanding you have before and after data now to convince EPA skeptics, who did you get buy-in from in the beginning?
Yeah, great question. And the biggest leverage factor there was having a strong executive sponsor. So the person who was pushing this for us, with us from the beginning was a high-level physician in the organization. I feel like the fact that this person had physician next to his name was crucial in starting that buy-in process. And so I think that was the first part of getting any of that buy-in. When we reached barriers, and we certainly did, I mentioned it took a year from the time we started this project, probably another 6 months before that of thinking, started the project to actually get through the decision point that yes, we're going to implement this particular software device and go through all of the hoops. And anytime we got pushback, it was that strong sponsor who helped us. So I think this has answered the question, but biggest key is have that executive sponsor who can shake the trees if need be, or as I refer to them as bring the muscle when needed. But that was the first big piece of it. Does that answer the question?
I think so. Thank you so much, Philip. And it looks like we have time for one more question. And Luke, I'm going to ask you this one. If a medication is denied and the insurance request is a preferred medication that is on their formulary, how is the physician notified to choose another medication?
Sure. So there's a specific field that our PBM partners populate. That's essentially a note field where all of the information about the denial goes into. So sometimes PBMs will message back and let the provider know that it was denied, but there might be some other drugs that could be tried. So that would be one way. But the ideal workflow in that scenario is that because things are being done prospectively, a lot of times providers will be able to see in the formulary data or in that real-time prescription benefit response what the alternatives to that drug are. So they're making that decision as part of the prescribing process rather than retrospectively. But if for whatever reason they miss it or they decide to choose a drug that's off formulary, that messaging can still come back in the denial so the user can see that there might be an alternative that would be better suited for that patient, and then they can work with a provider to get that prescribed instead.
Great, thank you so much. It looks like we've now run out of time for questions, and I just want to thank our speakers for their time. In closing, to our audience, we want you to know that your feedback is very important to us. As you'll see on screen, at the bottom of the current slide is a link to an evaluation. A live clickable link can be found in the resource list as well as in the program evaluation widget at the bottom of your screen, and it will also appear in the slide window at the conclusion of the program. We would greatly appreciate your thoughts on our program today. Again, I would like to thank our speakers, Philip Kissick, Dalia Soleil, and Luke Forster Broughton. Thank you so much for joining us and sharing your knowledge on this topic. And to our listeners, thank you for putting your time aside today to watch our program. We hope you found it informative, and we look forward to providing you with other helpful programs in the future. Ladies and gentlemen, this concludes our program. Thank you again for joining us, and have a wonderful day.